So I'm Richard Butterworth. I'm one of the neurologists at Milton Keynes. I was just reflecting as I came in on this comment about hot and bothered. I thought she'd sold me a pup and it was going to be about HRT and menopause, looking at the demographics. But it's about, I'll talk a bit about the diagnostic difficulties. And again, either generously or being mean, Anna's given me 45 minutes. I am not going to bore you for 45 minutes. I very much want to make it interactive. Thank you. Lots of time for questions and answers. Equally, I appreciate that some of the slides do look like a shopping list of neurological conditions, but I try and sort of work through and talk through those with sort of meaningful points rather than just making it didactic. Didactic's boring for me, sure as hell boring for all of you, so please do interrupt me and so on, or correct me if I speak out of turn. Oh, wrong way. Failed at the first thing. So we're going to talk a bit about some of those common neurological or less common neurological conditions, if you like. A few other bits I'm going to add towards the bottom. I'm very mindful that there are speakers from the national charities for a number of these entities later in the day, so they're going to be talking, I suspect, far more comprehensively than I will. But my input is just about how do I get to a diagnosis, or how do neurologists get to a diagnosis? So this is not my femur, but I have broken my right femur many years ago. The diagnosis was really easy. It hurt like hell, and I had a lump sticking out of my side of my leg. So if you break a bone, it's really easy. You have an X-ray, it shows the fracture. The skill involves the surgeon and the anaesthetist putting you to sleep, putting you back together, the therapist and the nurses then rehabilitating you afterwards. And the thing about diagnosis is that we now live in a sort of society where everything is on tap. Everything is immediately available. Social media, Twitter, Snapchat rather, whatever, Instagram. The younger generation expect everything to be available at their fingertips instantly. We've all been in clinic and people are going, with Dr. Google. I don't mind Dr. Google. I always say to people, what do you think's going on? A lot of the time they get it right. A lot of the time they come up with, alien abduction. And also, we need to think about the media. Things like the Daily Mail will have some story about some new cure, some new diagnostic test that's coming to you, sometime soon. These tests for Alzheimer's that are going to come up, hopefully I'm retired by then, because it's going to take me 8 days a week. The expectations that we're going to have these rolling out of diagnostics is sadly not quite true. And also, there's an app for that. You can go on your phones, you can put in your symptoms, and it will tell you, rightly or wrongly, what's wrong with you, perhaps. So let's just take a step back. How do you reach a diagnosis? The first thing is you've got to have symptoms, whatever they are. It could be neurological or not. That may then lead to a label of an illness. I use that term very carefully. That illness may have pathological correlation. It may not. And this comes down to, diseases can have both physical and psychological components. So we have this triad. But also, it is an arrow, it's a spectrum. And a lot of what I see and other neurologists see are patients with normal, everyday life experiences. So you go upstairs and you go, oh, hang on, what did I come up for? And you go back downstairs. Okay? not this morning, but sometimes if you're giving a talk or the morning of an exam, your bowels are a bit loose. Okay, that's normal. You take the step on, you start forgetting things. You're leaving your kids from after school activities, you're not picking them up, you're missing dates, appointments, you're losing your way home, driving home. You've moved on, you might eventually reach a diagnosis of Alzheimer's. Equally, my queasy tummy, I start having diarrhea regularly, I'm losing a bit of weight, I might end up with a diagnosis of inflammatory bowel disease. But it is a spectrum. I'm trying to sort of explain to patients that a lot of your symptoms may just be part of normal everyday life. So, in the context of today, do I get it wrong? Yes, I do. Hopefully not too often. The benchmark for me is not that X-ray, it's what someone's brain looks like some years down the line. A lot of neurological diagnoses are based on neuropathology. Did we get it right? Did we not get it right? Clearly, you can't say to patients most of the time, can we just have a look inside your head and we'll let you know. So what do I do? So there are lots of people who played Sherlock Holmes. Cumberbatch is the last. So you take a history, and it's so important to get that history. And one of the things that I bang on about, I'm sure I sound like an old fart to the juniors, is how the skills of taking a history are being lost. And that's twofold. One, a lot of medicine is now checklist, algorithm driven. So you come in and someone works down this checklist rather than actually asking you what's wrong with you. Also, there's a whole sort of tsunami of copy paste on the electronic records because it's easier to do that. So I think a lot of doctors have lost the nuances of taking a detailed history. And the examples I use is, dear Dr. B, please see this person with dizziness. Full stop, yours sincerely. And I write back, happy to do so. Will you see my patient with pain? Full stop, yours sincerely. And they say, well, is it chest pain, back pain, leg pain? And I go, exactly. Dizziness, it doesn't tell me anything. It's because you failed to then ask the next question of the patient is, what do you mean by dizziness? So what do I do in clinic all the time? I listen to stories again and again and again. And I've been doing it enough now that I've reached a stage where I can do almost on sleep mode autopilot. And then someone will just say something and I say, that's interesting. Could I just come back to you on that? I examine you. And no one tells you when you're a junior doctor, the older you get, you examine people less because you've got the skills of taking the history so comprehensively. You know where you're going. You know what the likely outcomes are, what the likely diagnoses are. And equally, I remember being taught as a student, it was a process. You take a history, you examine them, you get a problem list and a differential list. I don't do that. I go out in the waiting room, but I call you in. Have you come on your own? If you're 16 and female and come on your own, that's a red flag. If you're 35 male and you come with your mum, that's also a bit of a red flag. So I'm already taking on information. I watch you walk down the corridor. Just talking to you, I'm looking at your body language. When I ask you a question, do you answer or do you look to your spouse? So it's not a case of I take the history and then I start examining. All the time, I'm just taking in this information. So I watch you. Your body language, your gait. Do you answer the questions? Who do you come with? And I think sometimes as doctors, they don't quite appreciate how much information is there for free, if you like. So, How do you make a diagnosis? You listen to the story, you examine them, you make a clinical conclusion, a clinical diagnosis. The phenotype. Lots of, of course, all doctors tease other specialties. So the ribbing we get is, well, it's easy for you. You just do an MRI. And I go, no. I tell you, the MRI is going to show a problem exactly in that point. I'm putting my diagnostic skills on the line. The scan is to prove that and what the problem might be, not necessarily where the problem is. But we get paraclinical support, whether that's imaging, electrics, blood tests, it doesn't matter. And increasingly, genetic tests. So before 1993, if you were a bit twitchy and a bit fidgety, and your mum did it, and someone thought you had Huntington's disease, the diagnosis was made just on someone like me going, I think you've got HD. Whereas now, we have a genetic test to prove it. And increasingly, a lot of neurological conditions are proven or disproved with genetic tests. And often you do genetic tests and find results and you go, help, I don't know what to do with that. So, lots of doctors like to think they're really clever by diagnosing the rare and the ridiculous. Okay? At the end of the day, common things are common. And when the juniors come to me and say, oh, Dr. P, we've seen this person, blah, 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 I think they've got Creutzfeldt-Jakob disease. I go, well, that's interesting. That's 1 in a million per year. Milton Keynes should probably have 1 every 3 years. I take them back. This is Douglas Adams of Hitchhiker's Guide to the Galaxy fame. If it looks like a duck and it quacks like a duck, we have at least to consider the possibility that we have a small aquatic bird of the family Anatidae on our hands. In other words, look at the picture in front of you. If it looks like a duck and quacks like a duck, it's probably a duck, however much you want it to be something really rare. And I think a lot of medical education is that we're taught to diagnose the rare and the ridiculous, and we forget that common things are common. So, let's start with a more common condition. So, Parkinson's disease. This should be relatively straightforward. I've gone to the waiting room, I've called you in, you've sort of taken about 6 times to get out your chair, and you're sort of shuffling down the corridor. And when I was a registrar in London, there was a consultant I didn't work for, but colleagues did, who one summer day, he saw this lady being, it's a hot summer day like today, he saw the lady come off the ambulance outside, and he opened the window and said, "It's all right, love, I'll write to your GP," and just sort of ushered her back, because he'd decided that she had Parkinson's disease. I'm sure he was right, but that's not the way to treat people. So, the stooped, shuffling gait, loss of arm swing, that's the real killer sign. You watch them walk and they don't swing their arms. They may have a tremor, this sort of pill rolling, classically it's called. They look blank. I remember my mum was watching the program about who's the used to do Mastermind, Paxman. She'd watched a TV program recently about Jeremy Paxman talking about Parkinson's disease. And the next time I spoke to her, she said, "Do you know about the Parkinson's face?" And I was going, "Yes, Mum." I think so. That's what they do. And she was like, I wasn't quite sure what she was expecting, but they just look blank. There's just no animation. And increasingly, again, this comes down to taking the history. I say to them, I'm going to ask you some silly questions. And they often come back and go, well, that's an interesting question. And I go, they're all interesting. I'm not going to waste your time or mine asking you silly questions. pointless questions. People with Parkinson's have lost their sense of smell. People with Parkinson's are constipated. They become anxious like hell. If you were anxious before, you're now off the scale. You know, HRT and then some, or menopause and then some. And they have this thing called REM sleep behavior disorder where they act out their dreams. So they get vivid dreams, and in normal life, you have a break, so your muscles don't move, except your diaphragm and your eyes, but they don't have that handbrake, and so they lash out, punch, kick, often the spouse. And in the morning, they wake up and say, oh, I don't remember. So you ask the spouse, do they shout out in their sleep? Do they kick out? Do they punch? And they're either fighting off an intruder, or they think they're playing football for Arsenal and kicking a ball usually. But if you don't, all the clues asking the questions are, you know, if I see someone and they say, my smell's fine, I'm not bunged up, I'm not anxious, my sleep is fine, immediately I'm thinking, I'm not sure you have Parkinson's disease. But it comes down to taking the history. Motor neuron disease. I've framed this in the sense of, I know what the audience is today. When might you pick up a case of motor neuron disease that the doctors on the ward have missed because they've not thought about it? And classically, it's someone with a mini stroke, a TIA, for example, their speech. And instead of getting better, their speech is getting worse. The really sad things that we see once or twice a year locally is that someone has had progressive swallowing problems and no one's taken a history, so they've gone down the 2-week upper GI cancer route. They've had an endoscopy. They've had an abdominal CT scan. And the gastro team, who were seeing them as a sort of on this pathway, so you don't actually see the doctor, you just have the test, they go, well, we haven't found stomach cancer. Refer neurology. The patient comes in within 15 seconds when they're not talking clearly. You think, ouch, you've got motor neuron disease. And trying to tell doctors that if you can't swallow, the problem is there below. If you can't speak, the problem is there above. So it's not esophageal cancer. It's not stomach cancer. And Anna will know, because she and I have shared patients who are very, very angry. They've wasted 9 months. You haven't changed their ultimate outcome, but they've had 9 months less to come to terms with a diagnosis. And there's that thing, why has it taken you 2 minutes? Whereas up to, no one up to now has thought of this for 9 months, and it's because no one's taken a history. But also, I suppose, if you're a therapist and you're seeing someone with a stroke unit or one of the outlying medical wards, why is this person just not getting better from their apparent stroke? Why is this person who's had a fall at home, it should be just a straightforward mechanical fall, why is it they're not getting better? Is it that they've got an underlying degenerative condition that's like MND? Huntington's disease, I think this is about as crap as it gets, actually. I wouldn't want motor neuron disease, but I would know that I've got 2 years to plan and organise. I think HD is one step worse. I explain why. What are the clues? This is someone who is anxious, depressed, and they're just a bit fidgety, just a bit twitchy. And I've certainly seen referrals from psychiatrists. Dear Dr. B, please see this person we're seeing with anxiety or depression. They've got some funny movements. We think it's a side effect of their medication. When it comes to taking the history, what about your mum? What about your dad? What about your grandparents? And often there are just clues in the past history which come out if you ask the right questions. And of course, it may be that grandma was This could be 40 years ago, so pre-genetic tests. Oh, grandma had Parkinson's disease, but she killed herself. I've not had a single patient in MK with PD who's committed suicide. Okay? Do you think that's really, really unusual? Is it that they might have had HD? People say, oh, I was adopted. I don't know my family history. And this comes back to why it's so horrible. You know, there could have been this stigma in the family that, you know, the older people, they just go a bit weird and demented and they have funny movements and they fall over. And so these families often, not perhaps in the 21st century, but in the 1970s, 80s, whatever, children were just sort of adopted out. So you didn't want to know as a parent if you'd passed on this gene. So a clue is they say, well, I was adopted. And sometimes you ask families and they say, well, they've always been a bit odd. Uncle so-and-so's always just been a bit weird. There's just something about their personality that's not quite right. And again, in 2021, in the world of neurodisability, I suppose the same thing is thought about of people with autism, perhaps. But people just say, oh, he's always just been a bit odd. So these are just clues. If you don't sit up and think, well, why did grandma kill herself? You know, why were you put up for adoption, but your 3 siblings weren't, sort of thing? Or maybe they all were. Multiple system atrophy. This is Parkinson's disease with knobs on. And they often look like Parkinson's disease when you first see them. And then they just begin to fall off the rails. It might be 1 year, it may be 3 years, it may be 5 years down the line. And the clues are that they don't respond to medication well. They might initially respond to medication, but it's not levodopa, it's not really very good. Or they come back a year later and say, the medication has stopped working. Whereas Parkinson's disease has this sort of rest tremor, they sometimes have this quite very fine jerky tremor. But the bigger clues, I suppose, for the audience here, is that people with Parkinson's disease generally don't fall over in the first 2 or 3 years of diagnosis. I've seen it since COVID because I've seen patients who I've diagnosed in 2023 who probably should have been diagnosed in 2020. You just think, you've not seen a doctor for 3 or 4 years, so you're seeing someone already down the line. But most of the time, people with Parkinson's disease don't fall over early in the disease. People with MSA do. They come to clinic and they say, well, I've had a couple of falls in the last 6 months. You think, well, I only diagnosed you with Parkinson's last year. Why did you fall over? And there's this phrase, the wheelchair sign. You see them and they're wheeled in by their spouse and you think, have you broken your hip? Have you broken your ankle? Why are you in a wheelchair? Oh, I can't really stand anymore. You shouldn't be in a wheelchair with Parkinson's disease after 2 or 3 years. Or they come in with their sort of a head like this dropped neck. They just can't hold their head up. And it's not the only reason why people have that neurological symptom or sign, but it's just a clue that this might be MSA. And then they develop the autonomic dysfunction, which can be horrendous. And the difficulty is if you're seeing someone who is 70, they may well have some urinary dysfunction. They may well have lost erections, but they might be on a couple of blood pressure lowering agents, so they have a fall in blood pressure when they stand up. But if you start to get very prominent autonomic symptoms, you think multiple system atrophy. And the difference is they don't really respond to medication after a while. and a reduced life expectancy versus Parkinson's. And in a similar vein, progressive supranuclear palsy. They often start looking like Parkinson's disease and they don't respond well to treatment, or they might and then they stop. And again, they fall over. And often, particularly with the PSP patients, when you see them, they have already fallen. They've had a number of falls. Their voice is very different. It's this, everything is tight, there's dystonic in their larynx. It's a very squeaky voice. They have swallowing problems. People with Parkinson's disease have swallowing problems, but again, it's 10 years down the line. It's not when you first see them. They can't, part of the reason they have issues and they fall over is that with time, they lose the ability to look up and down. So with age, we all lose our ability to look up. That's just part of aging. But people with PSP end up as they can't look down. So when they're walking, they can't look at their feet. They lose this ability to look down. And there's this thing called the applause sign, which I say to patients, I'm going to show you, not yet, just wait. I'm going to show you this, and I want you to copy what I do. And I go. And someone with PSP goes. Okay? They can't stop themselves. They don't stop at that 3 claps. And what's interesting, and it's just a clue. People with Parkinson's don't do that. People with frontotemporal dementia, for a reason it's not clear, don't do that. People with PSP seem to have this distinct frontal disinhibition that they're just clapping. And it's just a sort of an icing on the cake clue that it might just not be Parkinson's. So, a bigger diagnostic thing is people who have what's called vascular Parkinsonism, or sometimes lower body Parkinsonism. And this, again, I've watched you walking, and they have shuffling steps, but they still swing their arms. And when they try and turn, I can turn naturally. They have this thing called on-block turning, where they go. And so it looks like a shuffling gait, except even though it's little steps, this march of little steps, they still swing their arms. And it's called lower body Parkinsonism because they don't have a tremor. They can do buttons, zips, shoelaces, bra straps. They can still sign their name. But their legs just stick to the floor and they have this shuffling gait. It does not respond to medication. And often they have a history of diabetes, hypertension, smoking, whatever. And sometimes it's just because they're 78, 80, 82. And you treat it with addressing vascular risk factors and input from therapists. Levodopa doesn't work. And then they often get associated cognitive decline, so vascular dementia. And this, it can be very hard for patients and families, and actually we get a lot of patients sent back from GPs saying, this person is getting worse. And we go, well, yes, sadly that's the nature of the illness. Levodopa medication is not going to help. What they need is support at home, therapists, and so on. So, very briefly, dementia. If you don't take your history and you don't examine someone and you did it over the phone, you'd get it right 2 times in 3 if you called everyone Alzheimer's. So Alzheimer's is by far the commonest cause of dementia. But we see other dementias, or Alzheimer's classically, that progressive memory impairment. You're getting lost, you're forgetting things, whether that's autobiographical, episodic memory. You're faltering in your memory, and when you're tested, you'll have issues in other cognitive domains, but primarily they seek help, or their family seeks help on their behalf because of progressive memory loss. Dementia with Lewy bodies, it's a case they're a bit Parkinsonian, so they're just shuffling a bit, but the clues are early and horrible hallucinations. They see people outside looking in at them from the garden. They phone the police because these children are always in their garden playing. They'll lay out an extra place at table because there's a man sitting there ready for dinner. So often these hallucinations, and they fluctuate. Alzheimer's, you never have a good day. It's bad all the time. Dementia with Lewy bodies, families say, well, they were really good last week, and I can't believe how, now they're bad this week, and they're good. And they're often very sleepy. They might sleep 10 hours at night. They'll have lunch and they'll have a 2 or 3 hour after lunch siesta. They've just become increasingly somnolent. The frontotemporal dementias tend to be people in their 50s and 60s rather than older with AD, but there's a whole raft of different subgroups depending whether it's a progressive memory problem, a language, or the most horrific with the behavioural change, either disinhibition, so sexual disinhibition, or gambling, or they just become apathetic and just sit and do nothing. Okay? And that can be soul destroying for families. And lastly, that sort of, if you don't know, we call it mixed dementia or sometimes vascular dementia. And that comes back to the vascular Parkinsonism. Right, slightly off topic, but I put it in. Functional neurological disorders. Okay? This does cause diagnostic problems. They have a wide array of symptoms. Name a symptom and I go, yeah, I've seen someone complain of that. Okay? And they often come with a shopping list of about 30 symptoms. And I've learned over the years to go, that's really good. Can I take your list? And can I annotate it? And I make a big thing of putting a hospital sticker on it. And I spend 2 minutes reading it, and I say, what are the big three? Because there's no way I can address all 30. What are the big three? And we talk about those. And they think Dr. B is a really nice doctor until they get halfway home and realise I've conned them and not talked about the other 27. But they come with a whole array of symptoms. And when you look through their hospital records, it comes down to whether, I said, you're a lumper or a splitter. They've seen the cardiologist and had a label of atypical chest pain. That means it's not ischemic heart disease. They've seen the respiratory physicians and it's got unexplained breathlessness. They've seen the gastroenterologist and they've got a label of irritable bowel syndrome. They've seen the gynecologist with unexplained pelvic pain. They've seen the rheumatologist and it's got a label of fibromyalgia. And you think, well, and they say, oh, look, I've got all these diagnoses. But it's all under the same umbrella. It's probably, you're seeing me for your sensory symptoms, your fatigue, your dizziness, your imbalance, your lightheadedness, your perceived memory problems. It's all part of the same entity. But when you see people in your context as therapists, these are the people who say, for example, I can't walk, I can't stand, whatever. When you examine them, their levels of disability exceed demonstrable impairments when you examine them. there's often inconsistencies when you examine them. So they can't move their arm, and then you ask them to take their jacket off, and just do it perfectly, and then they can't move it again. The difficulty comes is they often have structural pathology in addition, and that's a nightmare for them. And the example is, when I was a trainee, I was taught people have epilepsy, but people have non-epileptic seizures. What we realize is that very many people with epilepsy also have non-epileptic seizures, and that can be very difficult trying to separate and piece that out. And it's no surprise to the audience, they are major users of health service resources. And these patients go round different specialties back to their GP, who I'm sure he or she is just exasperated. And it sets a whole nother raft of referrals. And the patients and their families just become more and more disillusioned with the health service. So, look for clues, look for patterns, if it looks like a duck, etc. I have no problem saying to someone, I'm sorry, I don't know what's wrong with you. My concerns are, things will become clear in time, but wait and see. And if you frame that in a nice way, patients and families understand that. Not everyone. There'll be some who go, well, I don't see a proper doctor then, you can tell me what's wrong with me. But often with the neurodegenerative conditions, you just have to be honest and say, it's not like an x-ray with a broken leg. I can't take your brain out of your head, have a look, pop it back and go, yes, you do have Parkinson's, or you don't. Sometimes you have to play the wait and see test. But again, as a therapist and things, if this duck starts to look like a goose, you need to say, actually, something's not quite right here. Why are they falling? They shouldn't be falling, etc. Why are they getting worse when they should be getting better? And remember that therapists and nurses spend far more time with patients than the doctors on a ward round. So if you say, actually, this person should be getting better and they're not, or have you thought about this? Trust your instinct to go back to that medical team and say, this is no longer looking like a straightforward stroke. This is no longer looking like Parkinson's or whatever. Have you thought outside the box? Thank you.
Sounds good.
A very cold cup of tea.
Oh, sorry. Make you feel unwell. So, thank you very much, Dr. Butterworth. That was really informative, and hopefully it's sort of helped the audience. Has anyone got any questions? I'm sure you have. So, fire away. Vote of confidence here.
There can't be a stunned silence. Fire away.
So, I was happy when I saw you mention the FND, because we're just getting accustomed to residents with that at Eagle. So, I was just kind of wondering, because I noticed it's mostly young, it mostly affects people in there that are quite young. So I was just wondering if it's mostly diagnosed in young people or if it's across the spectrum.
So, again, I was told, older individuals don't have functional neurological disorders. Sometimes they do. I've seen it in response to people who were widowed, for example, and their life sort of falls apart. But you're right, the vast majority are young adults. Not all, but often they've had troubled paths, parents, divorced, bullied at school, abused sexually, neglect, whatever. So there's often not a happy home background, which they may not divulge unless you ask them. And often when you see them, what you hope is you see them early on, so you can actually explain in a positive way, this is not epilepsy. The difficulty is that if you see them when it's become chronic and entrenched, and the whole family sort of have this belief system that this is epilepsy when it's not, you can't change anything. And I'm not saying many patients. Some people come in and go, "I've got an FND." And I go, "Whoa, that's wearing it as a badge of honour." Most patients don't like it, and when you explain to families and so on, I suspect sometimes you're picking up. You're suggesting to them that the home might not be happy, their childhood may not have been as happy as it could be. Families often then put up barriers. No, you're wrong. And you often see them as the fourth, the fifth, the sixth neurologist. And they hope that you're going to say, it's multiple sclerosis. And everyone else is wrong. And part of it is that if you say, I've got breast cancer, everyone feels very sorry for you. If you say, I've got leukemia, everyone says, oh, that's crap, I'm really sorry. MS, pretty close. If you say, I've got an FND, they go, oh, God, I've got to go now. It doesn't have that same emotional. Politicians are not going to fight for you with a functional neurological disorder in the way they're going to fight for you with a breast cancer or leukemia diagnosis. So we've got to change the way we think about them and say, they have real problems. They have shit lives. And they're going to have shit lives for the next 30 years. They're not going to work. They're not going to get involved in society and so on. Because you're right, if you have someone who's 22 in a wheelchair for no real reason other than psychological distress, that's such a waste of their life.
Is there anything that can help delay the symptoms of MND, or are we getting any closer to that?
Delay the symptoms. So any diagnosis is a combination of genetics, environment, and a roll of the dice. So not all smokers get lung cancer, and not all lung cancer patients are smokers, but it comes back to the duck and looks like a duck. Most people with lung cancer are smokers. And if you improve public health and so on, so you don't die of your heart attack at 40 and your lung cancer at 50 from smoking, more people are moving into older age and then become vulnerable or at increased risk of neurodegenerative diseases. So the youngest MND I've diagnosed is 38. She'd given birth 5 months before to her daughter. It was horrible. But most are in their 60s and 70s, and it's just a thing of an aging nervous system. They're not all rugby league players or rugby union players.
But there's nothing that can slow down the progression.
So you can't. So if you're destined to get it at 62, there's nothing I can give you that's going to stop that.
But when you have it,
so the things that prolong survival are nutrition, non-invasive ventilation, and therapy support. Actually, I suspect the reason that Rob Burrows lived from 2019 until this year is his wife was a physio. I suspect he probably had a fantastic, if you like, professional care package. He had luck as well because he lived 5 years, but I suspect part of it was that he had a good support network. Probably, I'm sure he had an NG tube. I suspect he had non-invasive ventilation at home. They're the things that prolong survival.
You've got your Ridisol as well. That's for 3 months, and then the SOD one, there's some medication for that.
So the tablets I give you, I will say to you, this tablet does not make you feel any stronger, but across the population, it will extend your life between 90 and 100 days, between 90 and 120 days. Almost everyone starts it, most stop it, because they see themselves getting worse. There's a question there, and then I'll come to you.
What your patient met when you asked them psychological evaluation, is that part of your assessment as well?
So it comes back to how you frame it and how you communicate. I will say to you, nothing is 100% physical. Nothing is 100% psychological. I make it clear that mental health issues are just as debilitating as physical things. So, and then I'll frame it that, if you're in pain and you're under stress, the pain will be worse. If you're not sleeping well and you're under stress, you don't sleep well. And so I'll then explore, are there potential psychological stresses in your life? And I'll use examples I've seen other patients like you who have had, for example, X, Y, and Z. And you hope that opens up a conversation. Sometimes the result is that people do take that as a kind of affront and then clamp, oh, you're just like the other doctors who say it's all in my head. I go, I'm not saying that. And then you realize that probably their whole belief system is such to the point that I can't readily change that. Which comes back to trying to get them early. I haven't forgotten your question. During lockdown, there was this thing called TikTok tics. There were a couple of really helpful influencers who may or may not have had Tourette's, who decided to put on TikTok their TikTok tics. And it caused this explosion of teenagers, mostly girls, who were presenting with twitches and things. And I saw two in Milton Keynes. One girl, her passion was kickboxing. 4 or 5 nights a week, she used to kick shit out of people and things at a kickboxing club. The other one was a trampolinist, and she was either Bed, Bucks, Hearts, or South of England representative. Overnight with the pandemic, kickboxing gym closes, trampoline club closes. They lost their raison d'etre. They went to school and then they kicked shit out of people or they bounced a bit. And they both developed these tics. And when I explained to them, this was their body of manifesting their frustrations, their stresses, they bought it. Their families bought it. But it's not always, you're not always that lucky. Just Google TikTok tics, it's a real thing.
You mentioned nutrition and management of MND. Is it like a specific food group or is it quite tailored?
I'll spaghetti bolognese. I'll defer to our other expert, but the point is, it's you're losing muscle bulk, you're losing weight. It's a catabolic state. So you need to keep your nutritional calorie intake up and exceed. But more than that is that because swallowing can be so effective and so slow and so laboured, the worst thing you want is for you to spend 90 minutes trying to eat breakfast, 90 minutes lunch, 2 hours dinner. So I will say to you, if you like custard, if you like cream donuts, you have those. But you're not under that pressure to get in 2,500 calories because we will feed you overnight with nutritional support. So it's not an all or nothing. It's about trying to maintain their nutritional intake when you're fighting against a catabolic state. Is that fair?
Any other questions? Thank you very much. That's brilliant. Thank you.
Enjoy the rest of your day, everyone. I've now got to go and try and find a parking space at the hospital.
Good luck. Thank you so much.